I think the total picture of African countries, especially for the slum people in Africa. And there are some similarities also, slum people in Africa and slum people also in Dhaka. And yes, again, thanks to Mr. Tim. My last request would be to Mr. Dr. Simon Mariwa, Senior Lecturer, Department of Geography and Regional Planning, University of Cape Coast. Please, Dr. Simon Mariwa. Simon Mariwa has a research interest in environmental management, poverty, rural development, and resource management, and he has vast experience in practical training in ecological alternatives in sanitation in Sweden. He is a visiting fellow in International Studies at the Watson Institute of International Studies, Brown University, the USA. Yes, Mr. Simon Mariwa, you are requested to present your paper. And I want to remind you that the time is 15 minutes.
All right, thank you very much, Mr. Chair. Good afternoon. My presentation is on sanitation as the neglected mainstream of water in achieving the MDGs in Ghana. In fact, inadequate access to water and sanitation, as we all know, have been implicated in a number of mortality and mobility situations all over the world. For instance, it's estimated that about 5.7% of Delhi's and 4% of all year loss of life is also related to the issue of water and sanitation. And you all know diarrhea alone kills about 1.5 million children every year, and this gets even more than a combined toll of AIDS, malaria, and measles when we put them together. And alongside poor water quality, lack of sanitation, and poor hygiene are the main culprits for these situations. As a result of this, in 2000, as we all know, the MDGs were set up, and Target 10 sought to halve by 2015 the proportion of people without sustainable access to safe drinking water and sanitation. Once we know that water and sanitation targets lag behind most of the MDGs, in fact, we can see that the sanitation gap is about 3 times that of water. This means that even though water and sanitation are semi-things, as I may call them, because in most cases and in most countries you can see that institutions that deal with water and sanitation issues are put together, and we see that water and sanitation are always seen to be twins, and for that matter, one cannot survive without the other. But what is the issue? If you come to Ghana, we have already achieved the target for water. But sanitation, we are likely, not just likely, we cannot achieve it. And we know that sanitation interventions, according to basic statistics, indicates that it reduces diarrhea and other diseases far more than water interventions. Because the basic thing is that water is clean unless polluted. And one of the major sources of pollution of water has to do with poor sanitation. So what we're saying here is that we have the basic question: why has sanitation been neglected over the years? If you know that the sanitation interventions have this positive effects on health, why has it been neglected over the years? And this is particularly more important for Ghana, that has achieved a lower middle income country, because the thinking is that as countries improve in terms of economics, in terms of the stability, increases in income, it's expected that increased access to sanitation is also there. So this paper seeks to examine the spatio-temporal variation in sanitation gap in Ghana and assess the factors that have impeded sanitation provision in the country. Conceptually, we think that sanitation practices and decision making do not take place in a vacuum. What we're saying is that they are embedded and shaped by complex social, political, and economic structures and processes that are both historically deep and geographically broad, so differences may exist, and there are several factors that may come balance multiple household needs when it comes to water and sanitation issues. And for that matter, in most households, the demand for improved sanitation may not be a priority unless other demands are met. This study look at two main sources of data. We have what we refer to as the user-based and provider-based data. Here we use Ghana Demographic and Health Survey, and we use the population and housing census in Ghana and the GMP estimates. And the provider-based or data that we use include the Ghana Community Water and Sanitation Agency data, and then we also look at parliamentary debates, looking at starting from the problems have been framed and developed. Now, this is a brief summary of water and sanitation in Ghana. Sanitation in Ghana, 13%, an increase from just 6% in 1990. And in rural areas, we can see that open defecation is still high. Open defecation is still high. You see that it's increasing from 29% in 1990 to 32% in 2011. So that tells you that there are a lot of people who are also, and look at shared facilities, and all that. So this is just a brief. But the question is that what factors have contributed to this? And that's the main focus of the family. Believe that all the health-related problems in the country, almost 80% were associated with water, impure water. But I said wrongly because, as I said earlier on, water was created pure and remained pure unless polluted. 2000, when they set up the MDGs, there was no goal or target for sanitation. It means that sanitation was not an issue. It was only added in 2002. So it means that adding sanitation as a target to MDGs was an afterthought. So it's not considered as a major issue. And you can look at that. UN had World Water Day since 1993. We only had World Sanitation Day in 2008 after 15 years. So this tells that locally, internationally, sanitation was not seen as a major issue. In Ghana, again, if you look at another challenge why we have low sanitation provision is that there's low investment in the infrastructure for development, because water and sanitation were set as a sector. But as early as 1914, Ghana had water treatment plant, and it was only in 1961 that we had the first sewage treatment plant in Ghana. So that tells you that in terms of water and sanitation, sanitation was also neglected. Yes, the third issue that explains this gap and the low access has to do with institutional bias. You know that Ghana Water and Sewage Corporation was established to deal with water and sanitation issues in the country, because it was seen that water and sanitation were twins, and for that matter, they should be treated and managed by a single institution. And subsequently, we can see a number of institutions that are put together to manage water and sanitation as a single unit. But in all the operations, major attentions in terms of investment, major attention in terms of management shifted from sanitation to water. Of course, because of the public good characteristics of sanitation, you know, when you defecate in the open, you do not bear the consequences alone. But when you are thirsty and you get water to drink, I think you get the satisfaction alone. So people think that sanitation becomes an uncommercial task and people were not willing to invest in it. Secondly, fourthly, we have inadequate political commitment to sanitation issues. Sanitation and water were just managed together, even though there was some kind of institutional bias. But in 1996, sanitation was decoupled from water. The official explanation was that we want to allow a decentralized decision making so that communities will be involved in sanitation. But in actual fact, the hidden agenda for this was to get rid of unwanted sanitation being unwanted, so that the water sector will become more attractive for commercial investment, because people were more willing to pay for water than sanitation. But the impact is there. Another factor has to do with the supply-driven approach to water, to sanitation. Sanitation was seen as a public good, so public investment went in the sense of providing public toilets. And public toilets were not meant for people in the community. In most cases, the public toilets that we have were supposed to be for the transient population in urban areas. But now, because of the system and people seeing it as the government responsibility, NGOs providing for toilets, they refuse to build toilets in their own homes. Even there are situations where landlords or house owners will convert their toilet facilities into additional rooms or storerooms because they have the thinking that they can get it outside. I stumbled on a finding or work by Water Aid in 2000, and I found that in northern Ghana in particular, and therefore should be avoided, whilst others believe that latrine use will strip users of their magical powers. So what it means is that even if you provide toilet facilities for them, all factors that have led to the neglect of sanitation, improved sanitation in Ghana. Among the Akans, which is the largest ethnic group in Ghana, it is believed that toilet facilities should be sited further away from home. So in most cases, people do not have their toilets in the house until recently. So what it means is that people will build their houses. You can see about 20-bedroom houses. There's no toilet facilities. So what it means here, the thinking is that toilet smells should be further away from their houses, otherwise it will. So these are the complex political, social, cultural issues that surround the neglect of sanitation in Ghana. So what it means here is that if you really want to improve sanitation, there's a need to see sanitation not just as toilets, but as a public health issue that needs to be tackled from the household demand perspective, rather than providing for them and thinking that it's a responsibility of an external agent that's supposed to go in. And that is why the Ghana's adoption of the community-led total sanitation in 2010 is it's a step in the right direction, where people are motivated to see the need to provide for their own toilet facilities rather than expecting external agencies to do that for them. Thank you very much.
Thank you. Thank you, Mr. And other regions. And water is given much importance to provide, but in case of sanitation, proper investment, political commitment is not up to the mark. This is explained in his presentation. Now 3 papers.
Have any questions, just please write it down on your, so that we can manage the time properly. So first presentation, second and third presentation. So if you are open to ask questions to the presenter for further point. Anyway, please, let me invite you to ask question here. And please mention.
Everyone, I'm Anagha from Sneha, India, Mumbai. This is question of first presentation where it was shared that myths and miscommunications related to menstruation and menarche. So first you have stated that there is...
Please, how many interviews did you conduct for your study? It's a very interesting study. How many interviews did you conduct for the study?
18.
Thank you.
Okay, thank you.
Model practices that you've identified here in Dhaka that might be a beacon of light for future interventions in the future?
18 girls in different slums, 3 slums. So my question is, can you explain that 18 girls, how many of them are poor and how many of them are extreme poor? Because you have proposed a few strategic actions to overcome this issue. So if we see the poor and extreme poor people, respondents in your question, so definitely the solutions or the strategies for overcoming these issues would be a little bit different, but I didn't see any specific actions proposed for those segregation of people. Thank you.
So fish is for the smell. The idea is that it causes the blood to smell and people will know. The turmeric or other spices are mentioned because people feel like it will make the blood stain and that will stay longer. Alongside that, you have others depending on the area they come from. To the second question about what are the model practices. So we believe that when you're approaching menstruation, menstrual hygiene, we help with access to facilities, so MHM-friendly toilets, we call them, with space for the girls to wash their clothes, to dry them. We teach them how to just the physical management of it. And we talk to them about things like food habits. So I would go into more detail, but possibly we don't have the time, so maybe I will talk to you later. As for that question, that's a very good question. So most of these girls would fall in the extreme poor category, but
so what is your recommendations, like your short-term, mid-term, long-term recommendation to overcome this water and sanitation problem of the region? Thank you.
My question is, like you say that about women's insecurity to use toilets at night, and is there an intervention designed or taken to reduce this insecurity, and what is your recommendation for this?
I must say that governments in the region have done very well compared to Africa in achieving the MDGs, particularly for water. We've had some challenges with sanitation, and some steps need to take place. Today I focused on one of the first very good steps that we can take, which is the step of actually understanding the issue from the poor people's perspective, for the short, medium, and long term. And the plan will only be workable if they are credible. And what do we mean by if they are credible? You need to have a plan that actually identifies what are the implementation steps that would, and to actually put budgets in place to make that happen. To have schools already identified to train the staff that you need. And so it's a holistic approach that we are proposing. Not one where what most of us are doing now in the sector is we make a plan because we want money. But that money comes, we don't know how to spend it because we don't have the people to deliver the plan. So we're looking for countries to have holistic plans. So that's the second one. So I talked about plan, I talked about the budget to do it, and then I talked about the capital, human resource to deliver that. But beyond that, we also need to then, particularly for water, begin to identify how do we ensure, in the face of climate change, that we secure our water resources. So if you look at most of your cities, most of us don't even bother. We just go where we have the taps, we open the taps and water flow. Where we don't have the taps, we wait for the water to come. But when you go to the supplier's perspective and ask the utility manager, his challenge is having to go 100 kilometers to bring in water, to treat, to serve the city. Some cities are now talking about desalinization because the fresh water is not there. So how do we secure water in the face, raw water in the face of climate change? So those are some of the steps in the short and long term that we need to take. On the question of insecurity for women in homes, I think the only solution really is how do we get to develop household sanitation in the long term. But in the long to use the toilet, for example, particularly in the slums, one is that their husbands don't even care. So if a man cares and is there to say, okay, fine, we don't have a toilet in the home, and my wife needs to go out there, and the wife feels comfortable that when she's home, the care of the husband for his wife, the care of the father for his daughter, who is a prey to the persons out there. And two, sometimes communities even ignore the fact that women are violated. When a woman reports a crime of rape or of violence, the men are the first person to laugh, including the fathers. The fathers feel embarrassed by the fact that their daughter says that or their wife said that. They might even say the wife has encouraged somebody to do that to them. So
this too. So my question is, how do you define the shared latrine? Because in our country, we have bitter experience in this regard. We have distributed latrine for 3 families, but finally we found that latrines, those latrines are basically used by 1 family. 2 families, they are not getting access because of their level of poverty or their economic condition. And some places we have seen three families are using, but it's not used properly and hygienically. So in your case, we have seen the shared latrine coverage is increasing, but how it is managed?
Assemblies that provide public toilet facilities for central places. And in those instances, as I indicated, once people find such toilets available, they even collapse their own household toilets and use it for other extra housing, so that once they know that now I can go to the public toilet to use it. And for public toilet, the problem has to do with the management. Sometimes people go to the toilet facility, especially when it is about getting full and they don't empty it. The management is the problem. Most managers are interested in the money and not the cleanliness of the place. So instead of people going to the public toilet, they will pay the money and they will not use the toilet hose itself. You see that they might be defecating around. And when this happens, it deters other people. They don't want to use it at all in the first place. So you see that people pay the money. Instead of entering the public toilet, they will just move behind the toilet and do their own thing. So in terms of management, it's always a challenge. I think there are very few places where public toilets are managed very well. In that instance, you see people patronize and they enjoy using it. But in most cases where people are so much into their money and they are not interested in the welfare of the people who pay to visit, then it's a major challenge. And when people also see that they have a public toilet to use, they don't think of their own. And that is why you can see that the increase from about 40-something% in urban areas to 72%. Because people are moving away from their own household, thinking that they can now have access to the public. And the UN, I think UNICEF and World Health Organization do not consider shared toilet facilities as improved toilet facilities because of access. When you need it badly, somebody might be there. And in the mornings, you can see people queuing in order to use the toilet, morning and in the evening. So when people cannot queue for long, they look for other alternatives. And that's even worse, because there is this general term referred to as the flying toilets, where people would do it in polythene bags, and in the night they throw it on the street. So because they cannot queue for long and they don't have toilets in their home. So it's a major problem, and I think that is why it is not considered as an improved source of sanitation. I hope that helps. Thank you very much.
Thank you. If it's not there, then I understand what to do.
Yes, thank you, Dr. Ray. And at this stage, we want to listen some comments and opinions from Dr. Khairul Islam, the country president of Water Aid Bangladesh. Please.
Thank you, respected chair and presenters and audience. Good afternoon. I think the three papers which have been presented, those three have got certain linkages. The first paper showed the plight of women, especially during the time of menstruation in the low-income settlement in urban context. Simon has shown that the plight of sanitation situation in Ghana, but also by citing examples from the other countries and the trend. And what he argued is that Tinian's paper, the way I perceived, is actually is in the same line, but he could demonstrate some thought-provoking and glaring examples from golf course and Kibar Aslam, and showing some good examples from elsewhere. What he wanted to demonstrate is that definitely the world has invested a lot in terms of resolving the problems of drinking water, and probably the MDG target has been met. But sanitation and hygiene remain grossly underinvested, and this is possible that we can divert resources, but it's a matter of political decision. From these discussions, what we gather is that the political economy of water, sanitation, and hygiene has long been undermined. We, the scientific community in water, sanitation, hygiene, and health, we have argued in favor of public goods, in favor of health implications of water, sanitation, and hygiene, but somehow we didn't relate the political dimension of decision making and linking those and linking the activism and advocacy for WASH, for implications and betterment of health. And in this connection, I would like to refresh your memory because this is a conference on urban health, and I would like to draw your attention to 1978 when the primary health care definition was adopted in Alma-Ata by WHO, where water, sanitation, and hygiene and behavior change communication, at that time we used to call information, education, and motivation or communication, were integral part of primary health care. But over the years, somehow, with the persuasion of economic value of health and investment in health more from the economic terms, we deviated from that definition and dwelled into essential service package. And this is why these days we do not see emphasis of water, sanitation, and hygiene in primary health care. And this is one of the main reasons that health community, especially the public health fraternity, talks about water, sanitation, and hygiene, its importance in maintaining reproductive health, its importance in maintaining maternal health, and general well-being in general being discussed upon, but the health fraternity, the public health fraternity, do not invest a single dollar on those areas. And in this country, and perhaps this will be equally applicable to many other countries, that the primary health infrastructure for the urban poor has remained neglected. The way we have invested, even in this country, on rural health infrastructure, we haven't invested in the similar way in urban context. We feel proud to say that if you go to rural areas of Bangladesh, you will be seeing for every 6,000 population, there is a community clinic standing. If you go to any rural health center, you will be seeing that for every 4,500 population, there is a family welfare assistant who is talking about family planning, maternal child health. There is for every 5,000 population, one health assistant who is going door to door promoting immunization and other facets of elements of primary health care. But you don't see the reciprocation of this similar infrastructure, human resource, and primary health care facility for the corresponding urban poor. In that aspect, we are basically doing inequitable investment in primary health care, not only in this country. I can argue, if you take the stock of India, Pakistan, Nepal, and all the regions, we are probably doing an inequitable kind of investment in terms of primary health care for the urban poor. This is where this particular conference on urban health should call upon that the infrastructure and system that we have developed for our rural poor, the similar level of facilities, the similar referral system, the similar kind of services should also be enjoyed by their counterpart, urban poor population, low-income settlement in this country. And in that primary health care definition, we must not neglect water, sanitation, and hygiene. If we neglect, we will be neglecting our nutrition, intellect of our children, and nutrition of our children, and we may not get an intelligent and well-nourished next generation. So for this, from this conference, we should really make a call that let's embrace primary health care as it was adopted in Alma-Ata, and let's believe in it, let's invest in it. Let's not make any further lip services that yes, it is important, but deliberations that from this conference, let's embrace primary health care with two important elements, water, sanitation, and hygiene and behavior change communication be integral part of urban healthcare services.
Session titling Breathing Water and Nutrition in Urban Cities of Bangladesh, but actually we have discussed the breathing water and nutrition in urban cities of the world. So I think you have enjoyed this session, and at this stage from my part I am Uttam Kumar Rai, Commercial Manager Dhaka Washa. Like to thank you all, the audience, the foreign delegates, the presenters and the guests, and to conclude this session, I now request the session chair to make some comments and declare the closing of the session.
Thank you for listening to this. Actually, Dr. Khairul has already summarized everything of today's session that we're feeling, but what I like to add with him that if you look into the urban health indicators, actually we can set so many indicators. Many of the indicators are not very common to us, but for understandable to common people. But generally we understand that it is water, it is